circuit support. So heart failure is a leading cause of death in public health concern all over the world, and the lifetime risk of heart failure population above 40 is 20%. Heart failure is considered as deadly as pancreatic cancer if left untreated, and around 5 million heart failure patients in the US, costing $30 billion on the economic as an economic burden. And heart transplantation always been limited to therapeutic option for patients with end-stage chronic heart failure. Increasing number of patients with refractory chronic heart failure and decreased number of organ donation have resulted in expanded waiting list and waiting times for heart transplantation. And here the mechanical support comes. So as an introduction, the improved survival with heart failure with reduced ejection fraction proven as a medical therapy, cardiac resynchronization therapy, implantable cardioverter defibrillator, heart transplant, and mechanical circulatory support. So the principles of treating heart failure is medical therapy, corrective surgical intervention, and cardiac support or replacement. Advanced treatment would be the appropriate medical treatment, including antihypertensives, diuretics, vasoactive inotropic therapy, and improving symptoms and slowing the progression of heart failure, with providing survival benefits. Some severe cases needing specific surgical interventions, such as revascularization, valve replacements, and ventricular restoration procedures. In selected patients, severe heart failure is refractory to guideline-directed medical therapy and considered candidates for cardiac transplantation or mechanical circulatory support. So currently there's like around 33 centers, maybe more, and participated in HEARTMATE 2 trial, and at that time, at the trial, and today there is 174 VADS centers in the US. Those are just a reminder of the the classification of NYHA classification of heart failure, and mostly the patients for mechanical circulatory support will be in NYHA 3-4. So the INTERMACS Interagency Registry for Mechanical Assisted Circulatory Support, INTERMACS levels are divided into 7 categories or levels, and depending on the patient situation, symptoms, and requirements of the device. And as you see that the INTERMACS level 1, the patient using ECMO or percutaneous support, 2 and LVAD. Here in 1 is unstable instability, in 2 intravenous support, but with some deterioration in other organ function. Here the patient on hemodynamic instability, stability with low intermediate doses of inotropes. I involved here some of the guidelines of the 2019 European Association of Cardiothoracic Surgery consensus, as it's most, as I found it's the most recent. It was published in May 2019. This is just a reminder of the classes of recommendation in general. Class 1 being there is evidence or general agreement of the specific recommendation, and class 3 being the harm or not recommended. So patient in general, the indications for long-term mechanical circulatory support, patients considered in patients following. If the NYHA class 3B and 4 and ejection fraction less than 25%, and at least one of the following. Sorry, I missed the first one, is that you have to look for any reversible causes, and any reversible causes should be ruled out, and this is a class 1. Okay, back to this one. So with the low ejection fraction and NYHA class 3 or 4, INTERMACS 2-4, inotrope dependence, progressive end organ dysfunction, peak oxygen consumption less than 12, and temporary mechanical support dependence. That will be eligible for mechanical circulatory support with the recommendation of class 2A. And on the other hand, it's also indicated in class 3B to 4 with ejection fraction less level to reverse any where maybe none of this available or there, but to reverse elevated pulmonary vascular resistance and potentially reversible renal failure, and to allow time for transplant contraindication to be reversed, just to prepare the patient and re-evaluate for possible transplant. Patients considered high risk of poor outcome with the long-term mechanical circulatory support, advanced age after careful evaluation can be considered class 2A. Peripheral vascular disease, depending on the severity, may be considered class 2B, and active systemic bacterial infection, harm, not recommended. Patients with controlled HIV, hepatitis B, hepatitis C, should be considered class 2A. Actually, I attended one of the videos, one of the physicians, cardiologists, mentioning one of his patients had HIV and actually put an LVAD, and then she got pregnant and delivered, and everybody is fine. So actually, LVAD probably reasonably can be considered in such patients. Poor glycemic control, patient with poor glycemic control, end organ complications may still be considered with class 2B, and patients on chronic dialysis may be considered, and patients with hemostatic deficiencies, coagulopathies may be considered, probably with the hematologic evaluation, class 2B. Untreated aortic regurgitation or mechanical aortic valve, it's not recommended unless it's treated. And untreated severe mitral stenosis, it's class 3.
So I have to add, Abdullah, معلش, بالنسبة لل 2Bs and the 3. And in regards to what you mentioned with HIV patients and pregnancy, we have to know that these are seldom cases, and we're not going to base our guidelines on seldom cases. That's why the evidence of A and B is very followed in regards to these recommendations. And as you see, all evidence base is B, and even C. So we have to be treating this case to case, and probably 1 in 1,000 cases they receive HIV. Not that HIV is untreatable disease; it's more and more controlled. So yes, I agree with you. In regards of mechanical aortic valve, it's also sort of prohibited when it comes to class 3. However, if the patient is young, if there is a good reserve in the RV, then you can go ahead and cross clamp and remove the mechanical and put bioprosthesis, whether it's sutureless valve or whether it's a stented sutureful valve. These are case to case indicated. However, generally we go only for class 1 and class 2A. That's what I want to highlight. Thank you.
Okay. Patients with irreversible liver dysfunction, not recommended, class 3. Poor neurological and cognitive function, class 3, not recommended. And with limited mobility, may after careful evaluation be considered, class 2B. Patients living alone suffering from depression or should undergo careful evaluation before implementing long-term support, which will require long-term monitoring and follow-up. And patients who suffer from dementia, not recommended to place VAD. And active substance abuse, not recommended. Patients with malignancies, considered if expected survival is more than 1 year, low recommendation, class 2B. So in general, indications for mechanical support would be just here mentioned to know the different indications and how it's different from each other, to whom they don't know it. So bridge to transplantation, so you put the patient on mechanical support to buy time until the patient gets a donor. And bridge to recovery, the patient, like one of the examples would be myocarditis or other indications, as a destination therapy for long-term with no alternatives. A bridge to decision, patient, this is mainly for patients on cardiogenic shock, use of short-term support, and evaluation for other long-term support, and bridge to candidacy. And so, as we mentioned before, so use the LVAD to improve end organ function, whether like other contraindication for heart transplant, and improving that, and then the patient will become a candidate or eligible for transplant. A bridge to transplantation. So bridge accounts for actually 26% of the LVAD implantation nowadays. And
Abdullah, just one thing. I'm sorry.
Yeah, sure. Hello. Dr. Firas, I don't think we can hear you.
Oh, I'm sorry. Okay, I want to comment on the fact that it's true. The EACTS guideline, the European guidelines, came a year ago, but the ISHLT guidelines remains the primary guidelines that's been followed worldwide, despite the fact it's 2013 published, but there is a new publication is going to come within the next few months. However, not much changes happens, and the 2019 European guidelines is still more or less similar to the 2013 ISHLT guidelines. I just want you to always refer into the ISHLT guidelines when it comes to the patient. Thank you.
Okay, thank you. Okay, so bridge to transplantation accounts for 26% of the LVAD implanted. Okay, this diagram from the ISHLT and showing the percentage of patients bridged with mechanical support by diagnosis. So we have hypertrophic cardiomyopathy, ischemic cardiomyopathy, and transplant, and with different eras, and of course with different devices. And you can see that it's the red ones are increasing more and more with time. A bridge to candidacy is that, as I said, to more patients, you give the patient more time to more evaluation and to improve the end organ function as a possible to reevaluate the patient to assess if they're candidate for transplant. So 23% of the LVAD and INTERMACS database are bridge to decision or bridge to candidacy. So in those circumstances, the implantation is life-saving, improve secondary organ function, reduce pulmonary hypertension, enable improvement of the nutritional status. If it's a contraindication, the patient, like let's say, not a candidate for transplant because he's cachectic, or and all help to improve survival post-transplant. As a destination therapy, long-term use of LVADs an alternative to transplantation with the scarcity and the low donors availability. And LVADs is more durable than the previous devices, and the survival, 2 years survival is comparable to transplantation. And yeah. As a bridge to recovery, I think we already mentioned that. Let's go. Okay, move to the devices options. There are, like, let's say, three or more generation of devices. The first generation was basically pneumatic or not continuous flow devices, and we're providing excellent hemodynamic support and improved survival, and compared to medical therapy in the REMATCH trial, and pulsatile flow through a pusher plate, relatively large housing, had large housing, and need for extensive surgical dissection to implant it in the thorax, and precludes implantation in small patients. We have small patients. Those devices were huge, difficult to put them, and long-term use is limited by high probability of device malfunction and infection. Of course, the first generation of devices were mainly trying to how you say it, copy the normal function of the heart, where you have the pulsatility, so basically had this pulsatility like function, and those moving parts increase the wear and tear between those parts, and in the end, those devices are more likely to get damaged or malfunction soon than the newer devices. This is the first implanted LVAD, and first to be approved as a LVAD, and percutaneous. It's actually paracorporeal, which means it's the pump itself is situating outside the body. And then the first HEARTMATE device. It's a pulsatile device. It was huge, and it was actually situated outside the thorax, in the abdominal cavity, and as you can see, here's the pump. Here's the inflow. When we say inflow and outflow, the inflow related to the pump itself. So inflow in the left ventricle, and it, if I'm not mistaken, was the first to be in the LV apex, and to the aorta. Okay, and then you have the drive line outside with the controller and the batteries. Here's the blood flowing. Here is the motor. This is just another picture of it. Yeah. Novocor is a different device. Had issues with thrombosis, and actually, with the high incidence of stroke, and did not gain popularity after that. This was the study that looked at the survival compared to the medical therapy. Sorry, this is the REMATCH trial, which compared the HEARTMATE to medical therapy, and the eligibility criteria for those patients were NYHA class 4, symptoms for 90 days on full medical treatment, and low ejection fraction, low cardiac index, high wedge, and peak auto consumption less than 14, or IV inotropes, ineligible, and they were ineligible for cardiac transplantation. LVAD survival compared to medical therapy was at 1 year 50% compared to 25%, and 23% compared to 8% with the medical therapy, and also with quality of life improvements with LVAD, and LVAD morbidity is still considerable, of course, with infection and mechanical malfunction at that time. Here's just a comparison again. Of course, LV dysfunction was here the significant difference, higher in the medical therapy, sepsis higher, of course, in the LVAD, and of course LVAD failure. Otherwise, you can see here cerebrovascular disease incident. Second generation try to solve the problems with the first generation by introducing continuous flow devices, rotary pump of axial flow design, and continuous flow pumps have only one moving part, so at the rotor, and hence much more durable and smaller, quieter, and surgical implantation is generally less traumatic, and have smaller driver lines, a lower rate of drive line infection. This was the HEARTMATE 2 THORATEC. It was still placed in the abdominal cavity, but as you can see, the device is smaller. This is
Abdullah, correction, Abdullah. So the second generation, like HEARTMATE 2, it was placed in the right above the diaphragm. So it's not intra-abdominal. However, we used to dissect the diaphragm furthermore and lower the diaphragm down so we can have a bigger pocket for the HEARTMATE 2. But it's not intra-abdominal. HEARTMATE 1 was intra-abdominal. It was an excellent device despite the fact that it was pulsatile device, but it had an excellent outcome in comparison to NovaCore and the other pulsatile device extracorporeal that was coming from the THORATEC. Continue, please.
Okay. This is just another picture of the HEARTMATE 2. Okay, here comes the Jarvik 2000. It's had a unique power delivery system based on cochlear implant, and it's a continuous flow axial pump, and it was intraventricular position with the whole pump sitting within the LB cavity. Next would be the Berlin heart. Berlin heart was the first device to be approved for the pediatric, FDA approved for the pediatric population. It was first implanted in, I believe, 1991 in Germany, and it has an operating speeds between 5,000 and 10,000. If I'm not mistaken, for us, it comes in an intracorporeal and extracorporeal, like implantable and paracorporeal.
Correct.
Yeah.
Correct. The reason why, because they have cannulas that is heparin coated for long term, and it can exit the chest wall or the subxiphoidal, and you can connect this to even CentriMag. So you can the advantage for Berlin heart is their cannulas. They have a beautiful sewing cuff that you can insert at the apex, and whether you connect it to an intracorporeal machine, rotary flow, or extracorporeal Berlin heart machine versus CentriMag or Rotaflow, it's still functional and has its good cardiac output. But whatever the intracorporeal had a higher stroke rate.
Okay, the intracorporeal as a device, the whole device, putting it in a patient, like is it a smaller device, like would fit pediatric, or not really? The intracorporeal only for adults?
The intracorporeal was for adult.
Okay. This is the paracorporeal device placed in a child. Probably currently it's one of the most famous or the known device for pediatric population. So in pediatric population, implanting just some of the recommendations from the same guidelines. Implantation of device with patient-device mismatch, of course, is not recommended, and mid to long-term mechanical circulatory support is anticipated. If mid and long-term support is anticipated, durable, implantable, or extracorporeal devices considered over over ECMO or ECLS support, and with a recommendation of 2A. And the patient need for mechanical circulatory support implantation of intracorporeal device LVAD and discharge to home can be considered. Patients with special population congenital heart disease requiring circulatory support, it's recommended to have careful evaluation of the cardiac morphological, ventricular physiological data and collateral vessels in terms of considering it for implantation. I don't know if you have a comment on the use of LVAD, Dr. Firas, on the congenital or adult congenital population. Hello?
Hello? I'm
Yes.
sorry.
Yeah.
I mean, my internet is not really functioning well.
It's okay. I was just asking if you have any comments on the use of mechanical circulatory support or LVAD in pediatric population. Sorry, congenital. Yeah.
So it's rare. It's not even reaching 15% in comparison to adult implantation, and we have the majority of surgeons are using the Berlin heart cannulas and paracorporeal. More and more for the past 3 years now, they started to utilize the heart wear, since it's a very small device, as an LVAD. And we, with our experience at King Faisal, we started to utilize HEARTMATE 3. So we have implanted 3 patients and transplanted 1 of them, and exchanged another one with a pump. It's about the pathology and dilated cardiomyopathy. The patient, even if he or she are small in size with 28 or 32 kilograms and BSA of 1.2, you still can implant it when you have a heart or pericardium of 20 centimeter because of dilated cardiomyopathy. So you can still get away with this. However, it is very well noted in the INTERMACS, in the ISHLT analysis for the past few years, teenager LVAD having worse outcome than patients who are above the age of 25 because of compliance. Thank you.
Okay, thank you. Yeah, this is the HEARTMATE 2 trial, and comparing it to the HEARTMATE 1. So primary was achieved in most patients, and 1 to 2 years survival was significantly higher in HEARTMATE 2 compared to HEARTMATE 1. So 1 year was for HEARTMATE 268 compared to 55, and 58 at 2 years compared to 24% as in HEARTMATE 1. And significant reductions in major adverse events such as device-related infection, 0.9 versus 0.48 events per year, non-device-related infection, and right heart failure, renal failure, and reduction in the late rate of rehospitalization. This is a table from Lawrence comparing the outcomes of adverse events of the continuous LVAD, the pulsatile LVAD, and rate of pump replacement was significantly less in the continuous flow LVAD, and even with the related infection, sepsis, respiratory failure, renal failure, arrhythmias, and rehospitalization. Okay, 3rd generation centrifugal pumps, where a long durability anticipated to be 5 to 10 years. Compact size, smaller sizes, minimize the risk of thrombus formation and hemolysis with the pump. So the HEARTMATE 3, the famous one, is fully levitated centrifugal flow device, commercially available in Europe, United States, and here in the region. Rotor spins at rates of 3,000 to 9,000 RPMs and generates up to 10 liter per minute blood flow. It incorporates rapid changes in rotor speed to create intrinsic artificial pump pulse. So this is the new thing in HEARTMATE 3, where it has some kind of artificial pulse, asynchronous with the native heartbeat, to reduce the status in the pump. And this actually developed in the better results or better pump thrombosis. This design thought to potentially decrease the shear stress and reduce the risk of pump thrombosis and possibly the systemic effects of loss of pulsatile flow. This is the HEARTMATE 3. As you can see, smaller devices, trapecardial, less space is required, and yeah, as you can see, the controller and the batteries and the driveline. Momentum 3, I believe Mohammed, if I'm not mistaken, we're going to present it in a journal club next week in details, but in general, patients with advanced heart failure, fully magnetic levitated centrifugal flow pump was superior to mechanical bearing axial flow pump, which is the HEARTMATE 2, regard of survival of free disabling stroke or reoperation to replace or remove a malfunctioning device. Other option is the hardware, which looks very similar. I don't know, at least to me, it's similar to the HEARTMATE 3. Continuous flow centrifugal third generation pump, commercially available in Europe, United States, approved as a bridge to transplantation in 2012 and as a destination therapy in 2017. Much smaller than the earlier devices, talking about HEARTMATE 2. It was and parallel spins at rates between 1,800 to 4,000 with a flow of 10 liter. Results of comparing the hardware to centrifugal flow with the HEARTMATE 2, the patients included were 446 patients. The ratio was 2 to 1. The primary endpoint was survival at 2 years, free from disabling stroke or device removal for malfunction or failure. It was showed that it's not non-inferior to the control device, and survival rates were similar in study control groups. However, the study device, which is the hardware, had higher rates of stroke, around 30% compared to 12%, and patient control group had higher rates of device malfunction or device failure requiring replacement, which is the HEARTMATE 2. This is the MVAD system, a smaller device. I believe it's still under trial. I didn't find a lot of information about it, or maybe I didn't look in the right place. And it's a much smaller device. I read that some reported earlier pump thrombosis in many patients and earlier in the trial. I don't know, Dr. Firas, if you have comment on hardware devices.
No, you're right. There isn't much reports about the MVAD. And remember one thing, the smaller the device, the more common to have thrombosis and stroke. Remember the Circulate, which was a very small device that was implanted in the axillary area. It was extremely small, not percutaneous, but almost reaching the percutaneous, because you're right under the skin like a pacemaker and just attaching it to the axillary. However, it had a lot of complications. So I'm not really having big hopes on the MVAD in that regards. Circulite, however, I mean, MVAD is giving you much more flow. Circulite had of 2.5, so it was a partial mechanical circulatory support, not a complete one. But excellent, go, continue.
Okay. Okay. Another area is the biventricular support candidates. So patients with severe biventricular failure, predominant right ventricular failure.
Abdullah, kindly.
Yeah, please, go ahead.
Yeah, now, because I read before, actually we don't have, currently, and in my center, the experience like in King Faisal, they are leading regarding heart failure program, but I'm still I'm confusing about HEARTMATE 2 and 3, or maybe now the era of 3, and HEARTWIRE. So what I understand from my reading that there is a lot of complications, namely thrombosis and stroke, when they compare in the trial between HEARTMATE 2 and HEARTWIRE. And now we have HEARTMATE 3. This is supposed to be even better than HEARTMATE 2. So what is your advice from your experience, Dr. Firas? Let's say if I want to start a program, which device I have to choose? Because even I notice, even in many centers, they have both devices, but namely most of the centers, they go with the one device. Yani if I want to purchase, I want to go to which one of them?
So this is a good question, yet it can be political. HEARTWIRE is a very good device, and it has proven its quality and its good outcome. The problem that was happening with HEARTMATE 2 and HEARTWIRE comparison is it was unfair comparison, meaning the HEARTWIRE, when it started with double anticoagulation therapy, and they had more thrombosis. They overcome that by adding a third anticoagulation therapy or a dual antiplatelet. And that has improved their survival and lowered their risk of stroke and thrombosis, yet it had a higher chance of bleeding. Now, if you're asking to adopt 1 versus 2 devices, that depends on your center. If your center does 60, 80, 100 of VAD a year, then you can afford having a second device. Whether it's HEARTMATE 2 or HEARTMATE 3 or HEARTWIRE, you can still afford that, because in the end of the day, you're not talking about just utilizing any device or 2 devices. You talk about the comfort zone for the ECMO coordinators, VAD coordinators, CSICU nursing and physician, and even the cardiologist and the outside peripheries. You need to have a higher number, so you want to make sure that everyone is aware, and the higher number by having a higher volume passing through these paramedicals to deal with the consult, to deal with the patient, to deal with the parameters, and whether they increase it or decrease it, and the RPMs, because everything is different. The centers who are doing higher volume, mainly they divide it into 40 HEARTMATEs and 40 HEARTWIRE. Some is politically directed due to many reasons. So they choose one device. It depends on the support of the company for certain things. Me personally, I believe both devices are good. With our compliance, patient compliance, I prefer to tend to go towards HEARTMATE 3 since it has less risk of thrombosis and stroke and bleeding. Especially our patients don't really take regular medications such as warfarin. However, we did inquire the hardware in our center for the pediatric and for even some adults, and it's still feasible and we still believe in it. So the choice goes back to the center and their communication with the company, and for the patient compliance. And of course, the size of the patient.
Mm-hmm.
Did I answer your question?
Yes, especially then because hardware is smaller. This is why you may purchase hardware for smaller patient and for pediatric population. And what I know, it is smaller even than HEARTMATE 3.
Correct. Hardware is more user-friendly when you implant it into smaller spaces. So you're not gonna face a problem technical-wise. It's very easy to implant. However, I would be very concerned if the patient is not gonna comply into a triple anticoagulation therapy. So that I would be aware and cautious the family with it when I implant it for kids.
Clear.
Instead, in regards of the comparison, you mentioned HEARTMATE 2 to hardware. I think both devices proved to be equal. Lots of trials try to go lean towards one versus the other. I wouldn't believe any of them. I believe that HEARTMATE 2 and hardware are equal devices, but I don't believe HEARTMATE 3 and hardware are equal devices. In my view, HEARTMATE 3 is superior, much superior.
Superior in terms of bleeding?
In terms of thrombosis, thrombogenicity, and stroke.
Okay.
Dr. Firas, I noticed maybe a lot of centers in the States are still putting putting the hardware. Is it the cost also a big issue between the two devices? Like, is it the big difference between HEARTMATE 3 and hardware in terms of cost?
They're both are similar. Hardware in the beginning was high, and hospitals leaned towards HEARTMATE 2. HEARTMATE 3 came, and of course it's more expensive than HEARTMATE 2. So now they're both are equal. Both are insured in Europe and in the States, so you're not having that problem. Again, the center preferences is not due to the device, but due to the logistics, I would say.
Logistics. Okay. Thank you. Okay. But biventricular support, where the gray area comes, I believe severe biventricular failure, predominant in case of predominant right ventricular failure with significant ventricular disease, complex congenital heart disease, and patients who require long-term biventricular support. So THORATEC, PVAD, and for intermediate durability only, and the other option, total artificial heart, and use of hardware as a biventricular support, or HEARTMATE 3. This was the first total artificial heart to be implanted in human, called the TOTA, in Texas Heart Institute, and the results initially were good according to the Lawrence, but it did not gain popularity. The next device would be the SynCardia, where the only device FDA approved, the total artificial heart. Its contact surfaces are made of polyurethane and consist of 2 artificial ventricles, pneumatic pulsatile Medtronic valves, 70 ml stroke volume, of course, for each ventricle, and cardiac output 7 to 8 liters per minute. And the major drawbacks are the complexity of implant procedure and the size. Body surface area requires more than 1.7 meters squared. This is just a few pictures on implantation technique. So the ventriculectomy Here it's removed, and dotted lines at the valves. This is how it looks after everything is removed, and here after the device is implanted. To mention that it's a pulsatile device, and it's not continuous flow device, pneumatically driven. This is one of the pictures Dr. Firas last case. I took this picture. So, nice to look at. I don't know if you have any comments on Syncardia, Dr. Firas.
The only comments is I would say the 50 ml is for the smaller body surface area, which is less than 1.7, and you can implant it in 1.3. And the 70, as you mentioned, the 70 ml is that. I'm a little bit conserved about the sound of the Freedom console or of the console per se for the pneumatic total artificial heart and destination therapy, since it was approved as a destination. I would rather say that this should not be a destination. This should be a bridge to transplant patient. I believe it's an excellent device, and it can reanimate the renal, the liver function, the patient in general. And implanting it and expanding it is a nightmare. So not any center can do that. It should be in a center that can perform high volume VADS in general. But that's such a beautiful device, man. A picture, I mean. Thank you for putting it.
Thank you. Okay. Of course, with the turning into the continuous flow devices, and with better results with the VADS, now the manufacturer trying to produce a continuous flow total artificial heart, and this is the BIVECORE total artificial heart. It has basically a central magnetic levitated motor to provide the support, which is it. So only like a one moving part, which might have less wear and tear, and maybe I believe it's under investigation still on the trial in Texas Heart Institute. Still, it's under the trial. Yeah. So this is just a general recommendation for the biventricular support. So for predicting right heart failure, the use of clinical hemodynamic echocardiographic biochemical parameters should be considered, class 2A. Severe chronic biventricular failure, a BIVAD or a TOTA artificial heart should be considered, class 2A. Patients with refractory right heart failure after implantation of LVAD, early implantation of a temporary RVAD, such as CentriMag, should be considered, class 2A. Early RVAD implantation in case of right heart failure to decrease the morbidity and mortality should be considered, class 2A. Implantable BIVAD support may be considered in patients high risk for right ventricular failure, and 2 continuous flow LVADs, such as 2 HEARTMATE or 2 HeartWare, as an implantable BIVAD may be considered, class 2B. A total artificial heart may be indicated in patients with biventricular failure, patient restrictive cardiomyopathy, cardiac tumors, or large ventricular septal defects. Anatomical or clinical conditions that are not well served with LVAD or BIVAD, total artificial heart may be considered. I'm not sure this is clear to you, but this is just a nice summary of the trials involved in all the devices from the REMATCH until the Momentum 3, and showing the survival benefits. I'll be sending the slides later on. It's a good summary to look at. It's from the up-to-date.
So I would focus on the Momentum trial and the Magentum trial, and I don't know, you haven't mentioned the Magentum trial, which is the trial for the HEARTMATE 3 utilization of dual anticoagulation versus single anticoagulation, which is only warfarin. And they matched it with warfarin and aspirin. Also, they matched, the low INR of dropping down from 2 to 1.5. Remember, HEARTWARE is still 2.5 to 3.5, and HEARTMATE 2 was 2 to 2.5. Now, in Magentum trial, they dropped it to 1.5, and it was approved as a therapy with central antiplatelet therapy. The one thing I want to add also in regarding TOTA artificial heart, you have the CARMAT, which is ongoing trial right now in 4 countries in Europe. And the difference between the Syncardia and CARMAT is both are reliable. However, CARMAT has less sound from the console. The second is CARMAT has 4 biological prosthesis valves versus 4 mechanical prosthesis valves in the Syncardia. It's not yet approved, the CARMAT, but also it's ongoing. BIVENTRICULAR, I'm not really sure that it's going to have a hope. It's been in Texas Heart, developed by DeBakey, followed by now Fraser. And I believe it's going to take much longer time to catch with the 2 total artificial heart that I would say 1 total artificial heart in the market, but the second one is coming out soon.
What about, is there a device, I think it was mentioned in our book that Lawrence by Novicor, I believe, if I'm not mistaken. It's a pulsatile. Well, I didn't have the picture. Maybe next time you can put it. But yeah, it's interesting. What was it called? The one that's coming, Doctor?
CARMAT. It's French. CARMAT. It's developed by Alain Carpentier himself, and it's been conducted in 4 other countries. It was first conducted in France, and then had circuit failure. Then they reconducted it in 4 different countries. I believe they have performed 15 cases so far, and they had 0 death ever since. So I believe if this continues, the trial has been ongoing for a year. If it completes a 2nd year, I believe they will file for FDA.
Yeah. Now, Dr. Faras, you mentioned a trial that they use single antiplatelet without warfarin for HEARTMATE 3.
So yes, this is a trial just started, so there is no outcome of it yet.
Okay.
Yeah. It was just announced a few months ago.
Okay.
Yeah.
Okay. This is a list from Lawrence, just the different devices, manufacturing, and how it functions. You can see all continuous except the total artificial heart, and the FDA. All of them, of course, here the ones mentioned are FDA approved. So we'll start with the preoperative evaluation for mechanical support in general. So renal function optimization of renal function is class 1. Liver function evaluation is class 1. And in case of a patient with increasingly elevated bilirubin, temporary mechanical support ahead of the long-term mechanical support should be considered, class 2B. Case of pulmonary function, so treatment of pre-implant pulmonary edema is recommended before implanting like an LVAD and diuresing the patient. And left ventricular unloading on the extracorporeal life support to optimize lung function. And of course, respiratory physiotherapy, class 2A. Coagulation, withdrawal of dual antiplatelet therapy and the vitamin K antagonist to reduce risk of bleeding. In case of bleeding, what should be done? And use of short-acting intravenous anticoagulation as a bridging is recommended. And administration of procoagulants shortly before implantation. to correct coagulopathy. Class 2B, optimization of coagulation prior to surgery. Class 2A. Nutrition and metabolic and endocrine consideration. A preoperative assessment, metabolic, endocrine, nutritional status should be done before. Class 2A. Nutritional support if necessary. Class 2B. And in general, problems and complications are many. Cardiovascular would be failure of unsupported ventricle, like in the case of LVAD, the right ventricle, arrhythmia, cyanosis, shunting through the PFO, ischemia, angina, bleeding, end organ failure, infection, sensitization due to immune sensitization, giving a lot of products, and that then affecting the results of transplant. Decreased quality of life, and GI can be devastating with the GI bleeding, and device related will be thromboembolic incidents, obstruction, compression of the outflow, graft, improper orientation, device infection, device failure, bleeding, air embolism, and hemolysis. So in case of aortic valve and root disease, a biological valve replacement in patients with more than mild aortic insufficiency should be considered, class 2A. Central leaflet coaptation stitch may be considered, may be considered in more than mild aortic insufficiency, class 2B. Closure of the aortic valve, more than mild insufficiency, not recommended, harm. That it's recommended that functional bioprosthesis left in place, class 1, and replacement of mechanical aortic with biological is recommended, class 1. Closure of mechanical valve, aortic valve is not recommended, class 3, and correction of ascending aorta aneurysm at the time of implantation, class 2A. In case of a mitral valve disease, correction of moderate to or severe mitral stenosis recommended, and in selected patients, repair of severe mitral insufficiency may be considered, class 2B. Exchange of a functional mitral mechanical or biological prosthesis, if it's functional, it's not recommended, class 3. Previously treated patients with mitral clip, thorough evaluation to rule out the existence of mitral valve stenosis is recommended. Right heart problems, RV dysfunction, with incidence of 30% and 10 to 20% with LVADs require RVAD. That's why careful pre-op evaluation is good, is important. Suggested by right heart dysfunction, suggested by rising CVP, falling VAD flows, and right ventricular end diastolic pressure equal to CVP. Medical management would be avoiding volume overload, phosphodiesterase inhibitors, inhaled nitric oxide, prostaglandins, inotropes to increase the RV contractility and reduce after load through lowering the pulmonary vascular resistance. RVAD is required in refractory cases with low RV stroke work index, with higher CVP and lower PA pressures. In case of tricuspid insufficiency, those patients with the candidates for such mechanical support are prone to develop the tricuspid regurg because of dilatation of the tricuspid annulus and RV dysfunction, and associated with more length of stay and inotropic support. So the recommendation on those on such patients, correction of severe tricuspid stenosis recommended, re-evaluation with moderate to severe patients with moderate to severe tricuspid regurgitation after treatment with diuretic therapy, and tricuspid repair for moderate to severe regurgitation at the time of implantation, class 2B. Implantation of a biventricular assist device or TOTA artificial heart in patients with severe tricuspid regurgitation and right ventricular dysfunction may be considered, class 2B. Patients with PFO or ASD, and LVAD may exaggerate the right to left shunt through PFO, resulting in a profound desaturation. Remember that the LVAD is working on the left ventricle. There will be a gradient. Blood will flow from the right side to the left side. Hypoxic blood will go to the left side and less blood going to the lungs, and with all those problems. So any PFO is closed with of course, bicable cannulation technique. So the recommendation on those aspects, closure of patent foramen valley, percutaneous or at time of implantation, class 1, closure of iatrogenic atrial septal defect after transseptal intervention for any intervention such as tandem heart, class 1, intensive use of TEE in the operating room to guide the implantation, class 1, closure of ventricular septal defect during implantation, class 1, and unrepairable VSD, the implantation is not recommended. Bleeding, bleeding the most common complication, 20 to 50% of recipients of the devices. Late bleeding most commonly manifests as gastrointestinal or nasal bleeding. Of course, gastrointestinal commoner and more significant. And angiodysplasia formation, probably impaired platelet aggregation, like the mechanisms of those bleeding, such bleeding. And one suggested mechanism is acquired von Willebrand disease, is reduced or absent von Willebrand factor levels, more common with continuous flow devices and high flow from shear and tear. So management of anticoagulation, discontinuation in case of bleeding, discontinuation of anticoagulation and reversal of blood components. For minor bleeding, INR, if the INR is above therapeutic range, adjustment of anticoagulation agents should be considered, class 2A. In cases of bleeding, exploration and treatment of bleeding site should be considered, class 2A. After resolution of the first bleeding episode, the continuation of long-term aspirin should be considered. Usually for anticoagulation, usually no anticoagulation for the first 24 to 36 hours. Aspirin warfarin is started after that if no excessive bleeding. And target INRs, I think Dr. Firas explained it in case of HEARTMATE 3. Preoperative, if intraoperative ECMO support of pump implantation using only ECMO, administration of a reduced dose of heparin may be considered, class 2B. Early post-operative anticoagulation starting with intravenous anticoagulation followed by vitamin K antagonist is recommended. And use of low molecular weight heparin as early post-operative anticoagulation regimen should be considered, class 2A. INR ratio between 2 and 3 is recommended. Aspirin is recommended, class 1. Low molecular weight heparin for bridging during long-term support is recommended. And novel anticoagulation is not recommended.
معلش عبد الله السؤال
تفضل.
I think if the patient, if there is contraindication to warfarin, so what can we do? Any evidence for NOAC in the HEARTMATE 3 patients or no?
I don't know, Dr. Firas. I don't know. Dr. Firas?
So,
yeah.
So usually there is no contraindication for warfarin. Usually there are contraindication for heparin, which is the head syndrome, and there you can go to fundoperinox, etc., etc. If the patient is contraindicated to anticoagulation, then he should not be.
معلش الصوت ما فيه. I can't hear you.
Did you hear what I said?
No.
So what I'm saying is, simply, if the patient is contraindicated to anticoagulation, you do not select him for LVAD. If the patient, the only contraindication that's going to be, it's going to be against heparinization, and especially when you take the patient to the OR having ACT of 1,000, you're going to induce, and that's where you change the regimen of anticoagulation over the bypass machine. Any contraindication towards warfarin, you simply do not do LVAD. Is that clear?
Yeah, clear. But I think there is some evidence for the NOAC and LVAD patient. I don't know exactly it's approved or not.
No, it's not approved.
Oh, okay.
Yeah.
Mm-hmm.
Thank you.
Okay. Thank you. So in case of inability to achieve satisfactory flows, causes would be hypovolemia, kinking of the inflow or outflow lines, failure of the unassisted ventricle, ventricular arrhythmias, thrombosis of the device. Of course, management would be correcting those causes. Major infection, device-related, sepsis and device malfunction were most common causes of death in patients who received pulsatile flow and LVAD in the REMATCH trial. Within 3 months after implantation, probability of device infection was 28%. Continuous flow device reduced the rate of device infection by nearly half. Thromboembolism, the incidence is about 5 to 15% higher in the setting of clinically important infections. So on that aspect, the recommendation, echocardiography and CT, MRI, imaging a patient suspected of having intracardiac thrombus is recommended. Atrial fibrillation, in patients with atrial fibrillation, risk of thromboembolism increased from the left atrial appendage, and should be looked at with TEE. In patients with atrial fibrillation, left atrial appendage closure may be considered, class 2B. Left atrial ventricular thrombus is if present, removal of the thrombus is recommended, class 1. Left atrial thrombus, if it's present, occlusion of the left atrial appendage should be considered. RV or right atrium thrombi, cardiac imaging to exclude them, in particular before implanting the RVAD, should be considered. In case of arrhythmias, medical or surgical intervention, according to these society guidelines, is recommended. Routine implantation of ICD for primary prophylaxis before the long-term devices is not recommended. In patients with ICD, preoperative evaluation and possibility of implanting an ICD and the possibility of interaction should be evaluated, class 2B. Concomitant ventricular ablation during long-term mechanical support implantation may be considered, class 2B. Refractory recurrent ventricular arrhythmias, fibrillation, tachycardia, untreatable arrhythmogenic substrate, implantation of biventricular assist device or total artificial device should be considered, class 2A. Other conditions, such as in patients with previous redo cardiac surgery, a left thoracotomy approach for the implantation is recommended, class 2B. And patients with active infective endocarditis, not recommended, harm. Postponement of implantation may be considered. Patients with recent myocardial infarction, as the fragile tissues of the left ventricle, if it's the MI infecting the apex, and surgical or interventional revascularization at the time of implantation may be considered in patients with right ventricular ischemia, class 2B. Okay, surgical technique. So it's better to show it with the pictures, but so medial sternotomy, aortic cannulation, Okay, we'll go step by step. Actually, the guidelines explained it in steps. So choosing like cardiopulmonary bypass versus ECMO and LVAD implantation. So the use of cardiopulmonary bypass during implantation of a LVAD is class 2A. In case of non-necessary concomitant intracardiac procedures, you just the LVAD implantation, no other valve procedure or any other procedure. Use of ECMO may be considered class 2B. In off-pump implantation of the device, secured vascular access for a bailout cardiopulmonary bypass is recommended, class 1, as a safety measure. And in case of site preparation of the site of implantation of the device, non-intrapericardial devices, creation of a pump pocket by the left hemi diaphragm transection, as Dr. Firas explained, for the, like in case of HEARTMATE 2. Non-intrapericardial. Is that HEARTMATE 2 or I don't know, maybe previous?
It's HEARTMATE 3, the one we implant through thoracotomy. However, it has been done that pump exchange of HEARTMATE 2 through left thoracotomy is feasible, and it's even easier since you direct access to the pump per se. Did I answer your question?
Yes, no, this part was in non-intrapericardial devices, creation of pump pocket by left hemi diaphragm transection. I believe you explained something about the HEARTMATE, that you lower the diaphragm. HEARTMATE 2, sorry.
Exactly, but we always did it through the median sternotomy, where it's below the mammary, below the end of the mammary, where the bifurcation of the mammary, you start extending, cutting into the muscle and lowering the diaphragm furthermore, and extending further lateral to the wall. Trying not to open the pleura, but simply above the pleura, lowering everything down.
For intrapericardial case pericardial pouch, the device mismatch, incising the pericardium to allow pump placement in the left pleural cavity may be considered class 2B. So basically, I'll show video, which is like a short video about the implantation. And the device is basically a median sternotomy, and then whether it's by cardiopulmonary bypass or ECMO, and then the deciding the site of implantation of the inflow cannula, and deciding on the site with the echo by pressing on the LV, and the site usually should be. This is a picture of the one of the implantations. Here's Dr. Firas, Faisal, and Dr. Arfan implanting the cuff at the apex, and those are, I believe, maybe نعم دكتور. تفضل دكتور.
You missed the most important point. Go back to the picture after this.
أي واحدة هذه؟
You missed the most important point where the resident was doing the implantation, my friend.
That's the point.
I just want to make you guys jealous. That's the point.
I remember Faisal.
Continue.
I remember Faisal Falata was on leave, and this picture, I took it and you asked me to set it just to tease him. Okay, yeah. This is after planting the cuff, and okay, let's go to the details here. So the inflow cannula placement into the left ventricle is recommended with devices which is implantable and with the inflow cannula. class 1. Use of TEE to check where to put the inflow cannula is recommended, class 1. And the placement of inflow cannula parallel to the septum and not directed to the septum, just not to cause a suction event, class 1. And inflow cannula placement in the inferior left ventricle wall may be considered, class 2B. The placement of the inflow cannula in the lateral left ventricle wall is not recommended, class 3. Apical cuff positioning. So apical cuff, the cuff itself, sewing it with the sew first and then cord technique without intraventricular manipulation necessary, class 1. Apical cuff fixing with sew first and then cord technique with interrupted pleated sutures or continuous sutures, class 2A. And apical cuff fixing with core first, then sew technique is recommended in intraventricular procedures. An example, thrombus removal, mitral valve repair are necessary, class 1. This is the outward tract. I believe I'd like to show it in the video. Just a second. This is the standard approach, mini sternotomy. Let's just fast forward here a bit. Standard sternotomy. Okay, here after the sternotomy, this is the LV. Maybe Dr. Firas, if you want to comment, I'll silence the volume.
So the way you're showing it is really good. Now this is the point where usually we do the inflow cut. As you see, lower at the lower left side of the finger, that's the LAD and that's the margin. You don't want to be lateral because they're going to be, the inflow cannula is going to be facing the septum. So you be very close to the LAD with the pleated suture that you start from that point. But it's exactly what you're showing. So please continue.
Okay.
And one point, he's putting his finger at the apex and asking the anesthesiologist to show it on TEE. So basically, it should be showing the finger part pointing at the mitral valve, and that's where the proper positioning for the inflow cannula. Go ahead.
Chunk of the myocardium. After putting the sutures, and then I believe that Dr. Firas, you prefer doing it by putting the what do you call it? This one, the core You put the sutures later on, or the same way?
I do the suture then core, rather than core then suture, because I want to avoid blood loss. I want to avoid air coming in, and air embolism. So basically, I suture all my stitches, and then I core at the end.
The black line where the sutures, the stitches are going, the black circle. And after securing it, making sure to put the device in the way that the outflow tract is this way, and there's a lock mechanism to it. It will lock, and the outflow the outflow cannula or the graft is will usually, as you know, like travel on the inferior surface and then along the lateral surface of the right side, right atrium. This is a drive line. This is
Abdullah, there is cannula near to the ascending aorta. What's that?
Cannula. I can't see it. Wait just a second. Hadi?
That's most probably the vent.
Okay.
He measured the size and then cut it. I believe at this time, so for us, the de-airing mode, where you allow the device to run at a low speed to
Exactly. So once the inflow cannula is secured and the drive line is tunneled, I connect the drive line to the battery, and before I start or while I'm sewing the anastomosis to the ascending aorta at the lateral wall, I put a small needle, the pink needle, and I start de-airing at 3,000 RPMs. I usually never use aortic root venting. I try to keep the, I try to do the minimum dissection, the minimum suturing on the aorta, because I know I'm going to come back and I want a neat heart ready for the transplant.
That's right. Okay. Yeah. As you can see, he's preparing the outflow the graft, and after measuring it, here is so the aortic anastomosis is usually at the greater curvature of the aorta. Between there is a cannula, an aortic cannula, between the aortic cannula and the ST junction, and the greater curvature, and it's recommended to anastomose it at 45 degrees, of course, with good de-airing.
And the reason for that is simply to avoid turbulence in the aortic root and make the outflow going. You can continue the video while I'm talking.
Yep.
And
Yep.
to make the outflow going smoothly with the curvature and the aortic arch to the descending. So that's why 45 degrees was the most suitable with this turbulence.
Mm-hmm.
Today we present minimal invasive implantation of left ventricular assist device to heart.
Okay, we're back. Okay, we talked about this. This is the outflow tract, taking it to the aorta here at this side, and here using, I believe, Teflon cuff, but okay. Okay, this is about the outflow graft. Outflow graft anastomosis and ascending aorta is recommended, class 1. Outflow graft ascending aortic anastomosis at 45 degrees angle to reduce the risk of late aortic insufficiency, class 2A. Surgical glue to secure the hemostasis of the graft aorta anastomosis, class 2B. Longitudinal line marker on the outflow graft to avoid twisting is recommended. Just to put a marker along the graft. When you do anastomosis, there is no twisting, class 1. And positioning of the outflow graft along the inferior right ventricle surface between the right atrium and the pericardium to avoid crossing the right ventricular outflow tract should be considered, class 2A. Outflow graft through the positioning the outflow graft through the transverse sinus onto posterior lateral aspect of the ascending aorta may be considered. Ways to air embolism prevention, of course, the carbon dioxide insufflation in the field, and Trendelenburg position at the time of de-airing. Liberal de-airing via the outflow tract is recommended with on-pump surgery, class 1. Oversewing or glue application on the outflow graft de-airing spot, class 2B. Careful de-airing strategy in the off-pump implantation, class 2A. Active suction, needle venting may be considered. Here the alternative strategies, I believe Dr. Firas mentioned it. Intrapericardial course of the outflow graft patient without previous cardiac surgical procedures is recommended. And outflow graft anastomosis to the descending aorta may be considered in redo patients and patients with severely calcified aorta. And left pleural cavity course of the outflow graft in redo implants with anastomosis to the ascending aorta. I believe so the graft will travel to the opposite direction on the left side of the heart up to the ascending aorta, class 2B. And in redo implants or for patients in whom an aortic anastomosis is not amenable, anastomosis of the outflow graft to the axillary artery may be considered. In this scenario, where you anastomosis the axillary artery, of course, distal banding of the axillary artery to avoid hyperperfusion to the limb is recommended, class 2B. This is about driveline tunneling and so externalization. So the course of driveline with intermediate incision, C-shape, to maximize the pump to exit site distance, class 2B, and to alleviate traction forces may be considered. Partial course of the driveline through the rectus abdominis muscle to enhance the barrier for infection is recommended, class 1. It's recommended that the portion of driveline covered in velar is completely intracorporeal. This is about using temporary biventricular support for the right side to support allow subsequent explant without sternal reopening should be considered, 2A. Implantable right ventricular assist device support insertion of the inflow cannula into the right atrium should be considered. And for implantable right ventricular assist device support, insertion to the inflow cannula to the right ventricle may be considered. Okay, so we came to the future. Where is the future direction? So advances in technology have led to creation of more durable devices, improved clinical outcomes for mechanical circulatory support devices recipients, and minimally invasive approaches for mechanical circulatory support will be developed. Mechanical circulatory support may be used across a wider spectrum of patients and purposes, and patients with less advanced heart failure may receive partial circulatory support to improve quality of life. Accumulation of clinical experience will allow consensus guidelines to be developed. And current rapid-paced technological progress, such as guidelines, may be outdated, and someone should be like updated. So take-home message: patient selection is the most important component to achieve good outcomes with mechanical assisted support devices. Elucidating the goal of support placement, whether bridge to transplant, destination therapy, bridge to decision, bridge to bridge, is crucial for appropriate patient and device selection. And optimizing RV function is the key after LVAD implantation. Thank you. That's it.
Thank you, Abdullah. This is seriously an excellent presentation at a level of a consultant. I'm very proud of you for preparing such a long topic and putting it in in one lecture. This is extremely difficult. I'm also quite impressed with the questions that has been asked by your colleagues. I think the level of knowledge and residency is reflecting the strength of the program that everyone is in. So any questions?
Thank you very much, Dr. Faraz. We really appreciate your presence and your support, and of course, very valuable input from you. Thank you.
Thank you very much, Dr. Faraz, for your attendance. And inshallah, in the future, we are looking more and more of your attendance with us in the academic activity, inshallah. Thank you. Thank you very much.
Habibi, attendance doesn't come for free. You guys need to take me out for dinner.
خلاص أبشر. حدد اليوم
اختار اليوم واحنا مستعدين.
It's really nice to get to know everyone and connect into جراحين المستقبل and the present, as a matter of fact. So بالعكس, with pleasure. Anytime you need the support for any topic of your thought and choice, please don't hesitate.
And also, I'm advising everyone who having a rotation in King Faisal to either in adult rotation or even if he did pediatric congenital rotation like many of us, if you attend one time with Dr. Faraz, one of the implantation of the LVAD, you will understand a lot. I have a pleasure to attend once with him while I was in congenital. So when you attend, you will understand a lot of these technical issue and also theoretical issue. So don't miss it, yani.
You're welcome only if you have a good sense of humor, because my OR is nothing but joke. But everyone is welcome, of course.
الله يديك العافية. ألف ألف شكر.
Thank you. يعطيك العافية دكتور فراس. Thank you.
يا هلا.